Amber Beisly, who is a PhD candidate in the Instructional Leadership and Academic Curriculum program. So let me go ahead and give Amber control of the screen so that she can get her presentation going. All right, it should be ready for you, Amber.
Okay, can you hear me?
Yes, ma'am.
Okay. Okay, when does my official time start?
Katie's ready for you whenever you are ready, but I just want to make sure you have control of the screen before we start. There you go. So we're ready whenever you are.
Okay. Hi, my name is Amber. I am going to be talking today about a 5-minute snippet from my dissertation. The topic in my dissertation really came from my interest and experiences that I had as a classroom teacher. When I was a classroom teacher, the last year I had a student named Danny, and Danny really excelled at times when we were doing inquiry-based instruction where he could guide his learning and ask questions and try and find out answers to his questions. But where he really struggled were in times where there was more strict behavioral requirements. So, for example, we're walking down the hallway or in the cafeteria, he had some times of struggle. So my interest is really trying to figure out a way to capture the things that Danny was really good at, but also try and understand how to improve the things that he was not so good at. The topic of my dissertation is a construct called Approaches to Learning, which generally includes things like curiosity, persistence, imagination, the way that children go about learning in a classroom environment. And it's really important when children are first coming to school, like in pre-kindergarten and kindergarten, because it helps them adjust to this new learning environment where they're going to have to do things like cooperate with peers, share toys, cooperate in learning situations, interact with a teacher, where they have to go out and learn in maybe a center on their own, and also where there are certain behavioral requirements, like they have to sit and listen to a teacher, pay attention, things like that. So Approaches to Learning is this construct that can really support them in their development. For some children, they have problems with their adjustment. My thing to advance the slide just went away. So I don't know how to, oh, there it goes. Anyway, sorry, so they have problems with adjustment. Sometimes this is called negative approaches to learning. And it can range from a variety of things that children do. Either they may not pay attention or engage with the teacher. They may have emotional outbursts. They may not interact with materials appropriately, all the way up to aggression. And it's really associated with children's academic achievement, because when they're not paying attention or they're not engaging, they tend to put themselves away from situations where they may learn. And then it gets into this sort of cyclical pattern where the may be associated with aggression or really prevents them from learning. But if we focus on their approaches to learning, it's a way to counteract those negative behaviors. In my dissertation, I hope to study this construct of approaches to learning, positive and negative approaches to learning, using something called a person-centered approach. So it's a little different than a variable-centered approach, which may look at relationships between variables, something that might be like in that top picture. A person-centered approach looks for groups of children who have similar characteristics across variables. And so for approaches to learning and these problems with adjustment, it tends to view behavior along a continuum. One of the things that I hope to get out of using this person-centered approach are these mixed profiles of children who have strengths and weaknesses. So there have not yet been studies of approaches to learning using these person-centered techniques, but there's some using school readiness that have found some interesting things where, for example, the middle study found children who were really aggressive, but who had better academic achievement compared to children who were more disengaged. My hope is that I will find children in my dissertation who have positive approaches to learning, perhaps alongside more negative behaviors, but that those positive approaches to learning will be associated with better academic outcomes. So where I'm at in the process now, all of the data's been collected, and I am just beginning to analyze it using this profile analysis to see what will come of it. The end.
Wonderful. Thank you so much. And thank you for coping with our little technical difficulty there. I'm going to go ahead and take back control. So next up, we will have Dr. Drew Dawson, who is a fellow in the Child and Adolescent Psychiatry Program. So Drew, let me give you power of the screen, and then you should be able to scoot yourself along in the slides.
Okay. All right. Well, hey, yeah, everyone. I'm Dr. Drew Dawson. I'm a Child and Adolescent Psychiatry Fellow. I just wanted to talk about a little project that Dr. Tessa Manning and I are doing on agitation measurement and intervention at the Laureate Hospital on the Adult Behavioral Unit. So to give a basic overview of what we're doing, and we discuss on later slides, we're implementing a scale and instrument on quickly measuring agitation, as well as interventions and a protocol that will kind of follow along with that. Below our project, we kind of broke it up into two different periods. It starts off with surveying nursing and other psychiatric staff for like burnout using the Oldenburg burnout inventory, as well as a survey on perceptions of safety and communication. Then a 2-month period of doing business as usual, and that Laureate currently does, measuring seclusion and restraint events, emergency agitation codes, medications for agitation, as well as basic demographics. And we'll also be collecting from patients summary or surveys at discharge about, again, perceptions of safety and communication. Then after a couple months, implementing the protocol and collecting the same things for another 2 months. And at the conclusion, collecting surveys from nursing and other staff. So before we get into it, what is agitation? Well, APA tried to describe it as excessive motor activity associated with a feeling of inner tension. Well, that's kind of vague, but and that's why this scale is hoping to kind of characterize agitation. But it's a big problem with 1.7 million ER visits in the USA each year involving agitated patients. And it's a behavioral emergency requiring intervention. Well, our current guidelines are a series of papers published in the Western Journal of Emergency Medicine called Project Beta. And the overall goal of those is to make medication adjustments and based on what we think their diagnosis is and what's causing the agitation. But the overall goal isn't to like knock them out, it's to help them regain control and participate in care. Now, this is the workflow of our protocol, but as it currently works with agitation, nursing might notice a patient's getting agitated on the unit and they're throwing, hitting stuff or yelling, and they call the doctor and like, what do we do? Then maybe a medication is given, seclusion, restraint, and there can be a delay in care and agitation is picked up later. With our protocol, patients are admitted, assessed upon intake, and then triaged into mild, moderate, severe, or violent. And then an intervention is given based on that severity. And then if there's an intervention given, it's reassessed every hour until agitation drops to below a certain threshold. Otherwise, it's given every 12 hours. So here is our instrument. It's called the MASS, or Modified Agitation Severity Scale. It's based on a validated instrument called the Agitation Severity Scale, but that one was a little complicated and would take a long time for nursing to complete. So we simplified it and weighted symptoms 1, 2, 3, and 10, and that's based on the severity of the symptoms. So in the beginning, it's like red in the face will be kind of a minor weight, all the way to biting, a weight of 10. And this is easier to communicate from nursing to doctors, like, oh, well, this person's mass is 20, what do we do? And it's much quicker and able to communicate that. And for our, I want to focus on this table on the right. So this is basically the protocol. And if you'll notice that the mass scores are broken down into the 4 categories: the mild, very mild, mild, moderate, and severe. And interventions are available based on that score. So starting off, you can offer them quiet room, nicotine replacement therapy, talking with a therapist, and that will scale up to, in the mild category, having the option of offering like an oral medication. And then that continues to escalate to moderate, where an intramuscular injection may be appropriate to help the patient calm down and remain safe and not being violent with others or harming themselves. And that finally gets to the final category, where an additional option of crisis communication and restraint and seclusion is available. So our hypothesis with this implementation is that it will lower overall burnout amongst the psychiatric staff. It'll improve perceptions of safety and management of agitation from both staff and patients, and decrease workplace violence, as well as these emergency codes and overall agitation. Well, thanks for giving me the opportunity to tell you about my little project. If you have any questions, feel free to contact me at my email.
Wonderful. Thank you, Dr. Dawson. Okay, so let's see. Up next, we will have Kimberly Phillips, who is a PhD candidate in instructional leadership and academic curriculum. And Kimberly, oh, let's see. There you are. All right, you should hopefully be able to take control of the screen now. And then you'll just click the arrow to scooch along to your slide. Oh, and you'll want to pause it because the play just keeps it going pretty quickly, but it should be that right arrow. There you go.
Great, thank you. Well, my name is Kimberly Phillips. The title of my presentation is Invisible Inmates. It's a qualitative study on how children serve time along with their incarcerated mother. There we go, okay. When a mother is taken from her family, whether it's by death or incarceration, the ripple effect of the loss is felt by everyone, and it really adds an extra burden to her extended family, friends, and community members. And of course, the devastation that's left by her children. Children with an incarcerated mother are 5 times as likely to end up in prison themselves. Maternal incarceration leads to massive behavioral issues for children, and the family life becomes unstable. Their grades can suffer, and they experience a higher rate of aggression and depression as they struggle with the fallout of their parents' criminalization. Showing preserving a child's relationship with the mother benefits both the mother and the child while the mother is incarcerated. It benefits society, it reduces children's mental health issues and anxiety. It also facilitates a mother's re-entry into the community by having resources and supports readily available to her. And I don't know if you know, but almost 30,000 children in the state of Oklahoma currently have a parent that is incarcerated. And 2/3 of the women in Oklahoma that are incarcerated, which you know the United States of America has the highest rate for Oklahoma women, is their parents, their mothers. And so my research talks about, I had 6 participants. Sorry, I'm going to the next slide. It was a convenient sample. I started volunteering teaching at a women's prison facility in the state of Oklahoma about 2 years ago. And I just became fascinated with, I'm just going to say, the lack of support and benefits and resources that we have in the state of Oklahoma for helping mothers trying to reparent once they are released. They're all current residents of Oklahoma, and it was a case study paradigm and a qualitative approach. Children are impacted by having their mothers in prison, and it's not just a one-time event for them, but a daily reality that lasts for years to come. It's for children who have incarcerated mother when the main distributions in their life is having their life turned downside by changing the living arrangements. Most of my participants or luckily enough, they had a mother that were able to take care of their children, which was wonderful, but some do go into the foster care system, and some have to give up their children for adoption. But to children, a dysfunctional family is still better than no family at all, and they still want to reunite and have their mother in their life. I think I flipped the slide, but my qualitative approach included a questionnaire, interview, and a parenting log. And, oh, thank you. And one of the parenting logs, I had the participants write down different things. And one of the mothers wrote down that, you know, parenting is hard. You know, she was excited to get out of prison, but she forgot kind of, you know, the struggles that comes with working full time, you know, being back into society and living a clean life. Most of the mothers in Oklahoma prisons are in there for drug offenses, and not that they shouldn't be criminalized or punished for their issues, but, you know, we need to do a better job in the state of Oklahoma of reuniting the parents and children while they're incarcerated and definitely after they're incarcerated. My last slide. So mothers, most mothers are burdened by the past that got them into the criminal situation and their desire for a better future for their children. Because no matter how bad the mother's action may have been before being incarcerated, children still want their mothers, and mothers want to be a better parent and to be able to parent once they're released from prison. Thank you.
Wonderful, thank you. Okay. So, next up, we will have Elise Knowlton, who is a research assistant with the Department of Pediatrics. And Elise, I am working on getting you control of the screen, so just one moment.
Thank you.
Let's see. Oh. Thanks everyone for your patience as we work out our tech things. All right, Elise, I believe these are your slides, so take it away.
Yes, thank you, Alyssa, and thank you, Katie, for your support. So my name is Elise, and I will be sharing today work that I did for my master's at Oklahoma State University. We were interested in exploring what people know about ticks. So ticks are notorious transmitters of disease, and unfortunately, most of the diseases they transmit lack vaccines. And out in the environment, tick populations are very difficult to control or diminish. So this puts a lot of pressure on you as a host to be aware of ticks and where they are. So we surveyed college students, a convenient sample, and in this survey, we posed 7 statements and questions that challenge knowledge of tick biology. So let me direct you to the right side of the screen. On the x-axis, I have the statements 1 through 5 and the questions 1 and 2. And on the y-axis, I have the number of correct responses. And each course is designated with a letter, A, B, or C, that we surveyed. And we surveyed both at the beginning of the semester, and so the correct responses are in black. And we also surveyed students at the end of the semester. And so these graphs are actually showing the same students' beginning and end of semester responses. We had 224 students total. So if you were to actually blur your eyes for a moment and just look for general trends, you will see that statements 3, 4, and question 1 were the most challenging. We saw the fewest correct responses to those. So let me take those one by one. So for statement 3, we said ticks can jump, and the student was challenged to say true, not true, or they could say I don't know. And so both for the courses surveyed, we saw that in general, few students said false to ticks can jump. And for statement 4, which was also a challenging one, statement 4 said ticks reside up in trees. And so again, we saw a few students that answered false. In reality, if you have a tick on your scalp or on your shoulders, it's because the tick crawled there, not because the tick fell there. And similarly, ticks, they do not jump. They're actually waiting for you to brush up against them. So that's why knowing where they are in the habitat might be beneficial. So fortunately, most students correctly answered true to ticks live in the grass, both in the beginning and end of semester survey. And lastly, question 1, which was really challenging. Which of the following is the most prevalent disease spread by ticks in Oklahoma? We gave students 5 answer choices, and overwhelmingly, both at the beginning and end of the semester, students thought this was Lyme disease, when in actuality, Lyme disease is not transmitted in Oklahoma, and Rocky Mountain spotted fever is the most prevalent tick-borne disease. So overall, most students correctly chose the tick in a lineup of tick and insect images. And with that, just with that red box I have on those graphs, we were able to survey a similar course that had the same instructor and same curriculum, but we offered some supplemental education, which actually seemed to improve correct responses. So with that, I will just close by saying, if you go off trail, check yourself for ticks. And thanks so much, library. You're wonderful. I'll look forward to seeing you in person again soon. Bye now.
Thanks, Elise. Thank you for your presentation as well. All right. It looks like next up we have Samantha Murphy, who is a graduate research assistant in the College of Public Health. And Samantha, I am working on getting you power of the screen.
Thank you.
All right, it should be ready for you to take over.
Hi, I'm Samantha, and this is just a quick overview of the produce drop study, which is a randomized controlled trial using food as medicine to help improve chronic disease outcomes. So specifically, we're looking at uncontrolled hypertension and diabetes. So in the United States, there's about 75 million Americans who are living with hypertension and another 23 million living with diabetes. Between them, around less than a third of these patients actually adhere to recommended dietary guidelines. So self-management is a huge part of this, including adherence to dietary guidelines, which can help these patients significantly optimize their outcomes with these conditions. So unfortunately, food insecurity and poor nutrition literacy are common barriers among low-income patients, and these make it difficult to consume the recommended daily servings of fruit and vegetables. And then we found that even few clinicians even screen for food insecurity, and even if they do, there are few methods to actually combat food insecurity among these. So for this study, we're actually enrolling patients from the internal medicine clinic in the OU Physicians in Tulsa. So we have 2 different intervention groups. Both of these intervention groups will be receiving a weekly produce delivery. So each of these deliveries has about 8 to 10 different fruit, vegetable, and herb combinations. The second intervention group is also invited to participate in 3 cooking classes. So these cooking classes are about 2 hours each and are led by a professional chef and a healthcare professional. And then from these classes, we're hoping to build the nutritional knowledge that these patients would need to help improve their outcomes, like better controlled blood pressure and their glucose levels. So we're clinically measuring the changes in their blood pressure, weight, A1C every 3 months. So at a 3-month, 6-month, and then a final 9-month checkup, sorry. And then through other self-reported surveys, we're measuring how they feel that they're adhering to medication, food guidelines, their grocery shopping habits, how they see their access to food, things like that. We've also, so healthcare systems haven't really adequately provided avenues for healthy eating change among any low-income patients, despite the evidence that these changes towards healthy eating behaviors can actually have better improvements in these measures. So we hope that this study would help provide insight to the relative influences of these healthy eating, healthy food assistance programs, and then the addition of having that cooking knowledge and how that would help them in their daily lives through simple cooking and eating techniques instead of taking necessarily medications factors. Okay, that's about it. Thank you.
Thank you, Samantha. And next up, we actually have more about the produce drop. So let me, let's see, hand over control to Molly Martin, who is also a graduate research assistant with the College of Public Health. All right.
Okay.
Okay, Molly, I think the screen is ready for you.
Perfect. Thank you. And thank you for placing me so conveniently after Samantha. So as she said, my name is Molly Martin, and I'm going to be talking about the influence of food access and food security on fruit and vegetable intake. And this is all information that we gathered from our baseline data surveys in the Produce Drop study. So since Samantha just talked about a lot of this, I won't go too in-depth, but I wanted to do a brief recap about kind of the background of this project and why I decided to focus on food access and food insecurity in this presentation. So a lot of studies have shown that diet plays a really big role in the self-management of chronic diseases, particularly diabetes and hypertension, and that following therapeutic dietary guidelines can make a big difference in health outcomes, morbidity, and mortality. Unfortunately, only a third of patients with these diseases are meeting even the basic dietary recommendations for fruit and vegetable intake, which plays a big role in these diseases. And as Samantha stated, there are a lot of barriers to adhering to these dietary guidelines, specifically in our low-income populations. And one thing that I really wanted to look at was those kind of food security and food access barriers. We know that a lot of our patients have difficulty even getting to their clinic appointments, let alone getting to different grocery stores where different foods are available. So the Produce Drop study is a randomized controlled trial using food as medicine to improve health outcomes in chronic disease among OUIM patients. And here I have listed just a few of the validated measures that we used in our baseline surveys for our participants, particularly the food security survey from the USDA and a modified perceived nutrition environment survey, which lets people kind of say how they feel they're able to access foods. And so on this slide, we have the results of that community food environment survey, and these are just all the different percentages. So they were asked to, on a scale of strongly disagree to strongly agree, just talk about how they felt about these different things. So it's easy to buy fresh fruits and vegetables in my neighborhood. A majority of people did say that they thought that it was easy to buy fresh fruits and vegetables in their neighborhood, that they were available. About 61% agreed or strongly agreed with that, but only about half said that there was a large selection of fruits and vegetables, and even less, about 41%, said that the fresh produce in their neighborhood was of high quality. So the sense seemed to be that even though maybe there were fruit and vegetables out there and available in their neighborhood, it wasn't what they wanted, or they just didn't think it was very good quality. And then looking at food security status, so the USDA's food security score is scaled on a 0 to 6 scale, and we found an average of 4.1 in our sample. And so the majority had low or very low food security. And then we did a multiple regression model to look at how food security, community food access influenced fruit and vegetable intake, and that model showed that food security status but not community food access contributed significantly to that model. And so we just saw that with higher levels of food insecurity, there were less fruit and vegetable intake seen. So all of that to say that in our sample, we saw really a limited access to a large selection of high quality produce. And we thought that food insecurity was going to be a problem, but we really saw that it was a major issue among our participants. And so it just underlined again the need for innovative models of care, particularly in a community medicine environment, trying to look at those socioeconomic factors that contribute to health outcomes. So we're looking forward to seeing, as we do more follow-up surveys, if those scores improve over time and if models like this can be used in our clinics. Thank you all so much for your time.
Thank you, Molly. Up next, we have Eden Hemming, who is a data specialist with the Early Childhood Education Institute. And let's see. Okay, Eden, you should be able to take control.
All right. So I am presenting a project today that is a little more behind the scenes than the ones that everybody else has presented. We recently started talking about data documentation. We have several ongoing studies, but not a lot of documentation going on with them, or at least not a lot of concentrated documentation. And so we decided it would be a good idea to start README files for all of these studies. Too many times we've gotten to the analysis or publication phase and had questions, and trying to find the answer to the questions was difficult, if not impossible. So we wanted to make sure that we weren't slowing down the analysis and publication process. There we go. So the first step was to research the international standards, because there actually are international standards. I had no idea before we started this. And also look at the field-specific standards that we might have. There are lots of different standards, but there are common elements to all of them. Let's see if I can get it to advance. There we go. So then we gathered a few key stakeholders, which in our case was a project director, a researcher, and a member of our data core, which at the moment is mostly me. And we each handle the data that we have in different ways and at different times. So all of our input was important in order to make sure that we were, really capturing that process as best as we could. We also realized as we were going along that we could have included our personnel trainers and our PIs, because they're also important parts of the process. But right now we're just concentrating on one small part of it because it's such a big thing to do. So then the next thing we did was created and shared a template. This template was created from several university guides that they have on their websites. And also there is a study of all Head Start children across the nation called FACES 2014. And since we're in the field of education, we thought that would be a good place to start to kind of imitate their methods. So I used the university guides to figure out what the categories should be, and then arranged it according to FACES 2014's methods. Then we had a meeting with the study team leaders to show them what we had done and to get feedback, because each study has different needs and different abilities. Hang on a second, I lost my place. Yeah. So we had these meetings with each study team. We asked them what needs to be included from their study, what can be included from their study, and how to do it. The feedback that we're supposed to get from them is going to be happening next week, so we haven't actually gotten it yet. But once we have, we're going to bring everybody back together again and have one big meeting where we talk about some of the issues that come up and some of the solutions that everybody comes up with. And then our next step is to incorporate all of this into our regular processes. We'll assess what we learned from this process, and we'll also, anytime we start a new study, implement this from the beginning rather than in the middle like we are right now. And hopefully next year I can do another lightning round and tell you how that process goes.
Wonderful. Thank you, Eden. We look forward to hearing updates on how this project continues. Okay.
Thank you.
Yes, thank you. So unfortunately, Dr. Pandit is unable, to join us today. So we will be moving on to our final presentation. So give me one moment. We'll skip ahead in our slides. And so we will have our final presentation today with Felipe Oyarzo, who's a graduate student with the School of Social Work. And the screen should be ready for you to take control.
Okay, give me 1 second. I'm trying.
Oh yeah, take your time. I know there's a change in the lineup.
It's funny because I practiced this yesterday. And
that's okay. There should be some little arrows at the bottom of the screen. Do you see those?
Give me 1 second, please.
Of course.
No, I'm not seeing them. Give me 1 second.
Okay. So they're kind of on my screen. They're centered at the bottom. And there's a play button in the middle and then 2 arrows on either side.
Oh, there we go. Okay, I'm ready now. Okay, so this paper I'm presenting because it was selected for publication in several peer-reviewed journals. And what I'm doing, I'm presenting a new theory to the academia for social sciences. And it all started a few years ago when I worked as an advisor and as a researcher for the Ministry of Education of Chile. And the Minister of Education asked me if we could implement the Finnish educational system in Chile. So I did a long study, and I found out that the biggest barrier to implement the Finnish educational system in Chile were cultural differences. So the question came to my mind about if culture can be improved. And I did a literature review, and there's no one studying cultural improvement. So I came up with the theory of cultural improvement that opposes to the oppression theory elaborated by sociology. This was also this inspired feature film that we did that is right now competing in international film festivals. And we are actually negotiating the selling of the movie with Netflix. We should know by May, hopefully, fingers crossed, we'll do well. We'll see. Okay, so the cultural improvement theory basically suggests that cultures can be improved in order to facilitate social well-being as well as economic development. These are 2 things that most governments worry about. If, you know, for those who have experience working for governments, you know that it's a fact. I mean, usually advisors of governments usually have these 2 goals. I mean, how to facilitate social well-being and economic development. So right now, there is a very romantic view of cultures. Many suggest that cultures should be honored and respected as they are, but I disagree. And let me give you one example. Right now, in some places in Mexico, indigenous groups are selling minor girls for marriage, 12, 13-year-old girls. So I do believe that it's harmful for those individuals. So we approach negative elements of cultures of those elements that are harmful for people, okay? So let me go through this slide real quickly. We also approach an intellectual crisis in social sciences. Just to give you an example, some time ago we had a PhD on national television stating that mathematics are racist. Of course, I'm not gonna go deep into this, but while biologists are trying to find the cure for coronavirus, we have PhDs saying that, arguing that mathematics are racist. I mean, so we identified an intellectual crisis across social sciences, and that it's very worrying, actually. So we are proposing that the modern world, the new world, should start producing new intellectuals in our fields. We're using methods of anthropology to develop this study. And as I said, we identify problems with the oppression theory, and we identify that culture is the new gold, that countries, universities, research centers should look at culture more closely, especially in the modern world. We also suggest 7 stages for cultural improvement. This can be used by organizations, companies, universities, and governments. I mean, from families, for family therapy, to companies, and even an entire nation. And finally, so we did conduct a survey with 100 participants, and we discovered that most people don't know the importance of culture for social well-being and economic development. And we also studied a company, a US company, and the culture of Google, Facebook, Apple, and Microsoft. And we end our paper elaborating suggestions, recommendations for governments and other organizations. Thank you very, very much. If you are interested on this paper, it will be published in June.
All right, thank you very much, Felipe. And thank you again to all of our presenters. We really appreciated getting to learn more about your research, and we appreciate your flexibility in migrating to this virtual presentation platform. Thank you as well to all of the attendees who are able to join us today. We hope you enjoyed the presentations, and we hope you'll join us again tomorrow for a second round of lightning talks featuring OU-Tulsa faculty members. And again, if you haven't